Welcome to the conference session titled, What is Aplastic Anemia? Thank you for joining us. My name is Julie Powers, Senior Director of Patient Advocacy, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. Please feel free to submit questions at any time during the presentation from the Q&A icon on the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you've finished typing your question, hit enter. We will do our best to get to all questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. During the session, we will open and close polling questions from the audience to respond in real time using the polling feature on the right-hand engagement panel of the session. Please click on the icon in the panel to navigate between the two as you watch the session. Your response to the polling question will allow us to gather important information to help guide future educational opportunities for healthcare professionals and patients alike. Today's specialist is Bhumika Patel. Dr. Patel is a board-certified hematologist-oncologist who was appointed to the Cleveland Clinic Taussig Cancer Center in 2019, following 2 successful fellowships. Dr. Patel is an active researcher contributing to more than 40 studies over several years with a focus on bone marrow failure diseases. With that said, welcome to Dr. Patel.
Good morning, good afternoon, and good evening. Thank you for having me today to talk about aplastic anemia. I hope you guys will find this presentation useful, and I look forward to your questions at the end so we can interact and get to know each other better. So I thought we could get this presentation started with a clinical case that I think everyone can relate to it in some way. We have a 39-year-old female with no significant past medical history who presented with 2 to 3 week symptoms of a sore throat, which improved with antibiotics. After completing a course, she noticed increased bruising on her extremities, for which she went to her primary care doctor for evaluation. Some of the labs that she had done at the outside hospital, we obtained her labs. Her white blood cell count was 2.3, hemoglobin was 6.1, her platelets were 25, and her neutrophil count was 0.5. And other labs that were done is she tested positive for rheumatoid factor and absolute neutrophil of ANA. And when we repeated her labs on arrival in 2013, we noted that her labs she was severely pancytopenic, meaning that her white blood cell, hemoglobin, platelets were low along with her absolute neutrophil count. Other labs that we did at arrival, because we were thinking broadly about our differential, we wanted to check out her coags. So that's how thin or thick our blood may be. So we looked at her INR, and we looked at her percentage of her reticulocyte count. We looked at LDH. We looked at haptoglobulin because we wanted to see if there was any evidence of any blood cells being destroyed. Other things, because her ANA was positive, we wanted to look if she had a history of any autoimmune condition. So when we talk about blood cells, I always say the stem cell gives rise to all the bloods in our, to all the cell lines in our body. So it's the mother cell of all cells, and the 2 important cell lines that we always talk about in any type of myeloid disorder or any type of bone marrow failure condition is we talk about myeloid stem cells and lymphoid cells. Our myeloid stem cells give rise to our red blood cells, which carry oxygen, and platelets, which help us stop bleeding, and myeloid cells, which gives rise to eosinophils, basophils, and neutrophils, which are important for fighting infection. And important to keep in mind as we go along in our discussion. Other cells that are important also are lymphoid stem cells. They give rise to our B cells, which produce antibodies, T cells, which help fight off infections, along with our natural killer cells. When we talk about the spectrum of myeloid bone marrow disorders, it's a wide spectrum of disorders. And when we talk about this, I think this illustration is something I use, and I use it in clinical practice to explain that this is a continuum of disorders where there's a lot of overlap, but the thing is what gives us an idea of where the immune system is involved. So as you can tell, immune-mediated complications are seen to the far left. where you see aplastic anemia, pure red cell aplasia, dyskeratosis congenita, which is a congenital disorder. But we worry about the role of the immune system, especially in aplastic anemia, LGL, and PNH, and MDS, and other conditions. And we worry about the clonal process, which we look at genetic abnormalities of different disorders, in which now with next generation sequencing, which is genetic sequencing that can be performed at a lot of institutions, we look at the identification of molecular abnormalities in our DNA that can be present in some of these conditions. So our focus of our discussion as we started the title is aplastic anemia. And we know first clinical description of aplastic anemia was described in 1888 by Paul Ehrlich when a young woman who died of short illness marked by severe anemia, bleeding into skin, and with fevers. Like we discussed, the stem cell is the mother cell of all cells, and it's studied with the bone marrow where the cells came from. Bone marrow is the organ of all cell types. And one thing about aplastic anemia to keep in mind, it's a marked reduced cellularity and deficient in blood cell production to varying degrees. And for aplastic anemia is a disease of children and young adults with a peak incidence peaking around the age of 60 or older. And we have two different types of aplastic anemia. We have acquired or idiopathic, which we'll be focusing on mainly today, and we have inherited. PNH clones also, which we'll be tying in later on in this discussion, can be detected, is closely related to aplastic anemia in 40 to 50% of cases. But they're usually small, but it's something to keep in mind. Here we see a picture of a bone marrow sample where, as you can see, it's hypocellular. And when we talk about cellularity of the bone marrow, in a normal individual, the cellularity of the bone marrow decreases by every decade of life by 10%. So, but in aplastic anemia, the cellularity is very low per the age. And that's something to keep in mind as clinicians, and also when we're thinking about diagnosing our patients with aplastic anemia. So classification of aplastic anemia, as we know, is a disease of the bone marrow. So we're going to split it up into two different categories because I think it's important to know. So most cases of acquired aplastic anemia is idiopathic. We don't know the etiology of it, but we know it's an immune-mediated pathophysiology of this disease. But there are secondary causes of aplastic anemia, such as radiation, drugs, chemicals, nutritional deficiencies, viruses that can also cause aplastic anemia, and immune diseases such as eosinophilic fasciitis, thymomas, graft versus host disease, pregnancy, and is closely associated with PNH. So I think it's something important to keep in mind in your workup and when you're getting worked up for these conditions. Inherited aplastic anemias are closely associated with Fanconi anemia, dyskeratosis congenita, Schwachman-Diamond, and megakaryocytic thrombocytopenia, and pre-leukemia, monosomy 7. I think what's important to keep in mind between these two conditions is, so with the clinical case we talked about briefly, is that a young female had pancytopenia. We need to keep our differential broad because we know aplastic anemia is a rare condition. It happens in 1 to 2 million patients a year. So we want to keep our differential broad and get a good history. We want to see, well, she has pancytopenia, look at her past medical history, see any exposures patients may have. We also want to ask about family history, and we want to get an idea, but a physical exam is going to be imperative also. But keeping your differential broad is very crucial. So when we talk about the disease mechanism of aplastic anemia, most acquired aplastic anemia has an immune base, is an immune-mediated condition. So we talk about direct and indirect effects on the stem cells. So in this condition, medications, viruses, chemical in pregnancy and can cause indirect and direct effects on our immune system, which can cause destruction of the stem cells. But there's inherited causes also that can also cause issues with bone marrow failure, such as Fanconi anemia, short telomere syndrome, which are something important things to keep in mind in your differential when being worked up for aplastic anemia. Remember, our stem cell is the mother cell that gives rise to all of our cells, and it's important to keep in mind. In acquired aplastic anemia, when we're talking about the disease mechanism, we always think about is it immune related, but also our T cells are a big component of that, which we believe, which we know are a big component when the immune system is triggered, the T cells attack the stem cells. And that's something to keep in mind as we move along. So clinical presentation. So back to our, and many of you can relate to this, and I think our clinical case also will highlight this, is that there's low blood cells, meaning there's low platelets, there's increased risk of bleeding, there's bruising, you can have gum bleeding, and heavy and irregular menstrual cycle. And I think that's something to keep in mind for our women. Low hemoglobin can cause pallor, fatigue, shortness of breath. I've had a lot of patients tell me that, I realized that I couldn't exercise as much as I used to. And it was a slow onset of those symptoms. And low white blood cell count, many, like to our patient, infection that was, clearly wasn't clearing appropriately with antibiotics. So I think that's something to keep in mind when we're evaluating our patients, but also to keep in mind for yourself when you're being treated for these conditions, is that monitoring your symptoms is a crucial part. Exposure history is also important when we talk to our patients about, when we see a patient and we're like, hey, where have you traveled recently? And what exposures have you been, exposed to any type of new medications? And, we talk about that very closely. And we also talk about the family history because we want to talk about the potential inherited causes so we can work that up appropriately. So diagnostic workup. So when I see any of our patients with pancytopenia, I always like, okay, so we have pancytopenia, meaning low blood counts. So what I'm going to do is I'm going to, evaluate this patient, look at, get a complete blood count for them. Also, I'm going to get a bone marrow biopsy if all common causes have been ruled out, meaning nutritional deficiency, viral components, and other common things being ruled out. But it's going to be imperative for me to get a bone marrow biopsy with the aspirate because I want to make the diagnosis appropriately. Because the thing is, a couple of things that help us in making diagnosis is a diagnosis of exclusion, but also the bone marrow helps us in making that diagnosis. Because with your CBC, you'll be able to tell if there's low blood counts, but not only that, the cellularity of the bone marrow will be low, which helps us in making the diagnosis of aplastic anemia. Other testing that will also be done when you're concerned about aplastic anemia is you're going to get a flow cytometry for PNH, especially in acquired aplastic anemia. You can see a small clone in 40 to 50%, but you want to get cytogenetics because you want to look at the chromosomes because you can have hypocellular MDS, which is closely related and looks similar to aplastic anemia, but that may help you differentiate those conditions. We want to get cytology. We also want to do the DEB testing for Fanconi anemia, if that is the case. So we're going to get the chromosomal breakage test there. We get telomere measurements, and this is important because if we have ambiguous history, meaning we don't have all the moving parts of the history, we want to know. We know in the patients with aplastic anemia, they have short telomeres. But if there's a strong family history of where there's idiopathic pulmonary fibrosis or other conditions similar like liver cirrhosis, we want to make sure we get telomere measurements on those patients. But that is something that can be done as a part of the workup based upon the history. But another important component in aplastic anemia is getting HLA tissue typing for bone marrow transplant, and which we'll talk about as we move along, is the importance of that having that completed and making sure that's done early on, because the thing is that may be needed down the line in the future and or early on in your treatment. But our bone marrow is going to give us an idea of where we're going for acquired or inherited aplastic anemia, along with the additional laboratory workup. There's a lot of genetic, with amazing researchers out there around the world. We have been trying to understand, what is the genetic test to distinguish inherited versus acquired bone marrow failure syndrome. Large studies have been done in across the world in inherited and acquired bone marrow failure syndromes, where we've been better able to describe genetic abnormalities that are found in inherited conditions, as you can see here. Such as with Fanconi anemia, we look at the inheritance patterns, like how is it inherited from our parents to the individual affected by the underlying condition, and how we work that up. But what's important, like individually beyond Fanconi anemia, we want to look at dyskeratosis congenita, Shockley-Diamond, megakaryocytic thrombocytopenia, Diamond-Blackfan's anemia. As you see, there's so much genetic differences between each of these conditions, but that helps us with that good history physical exam and making sure we're appropriately treating our patients with inherited conditions. But even in a disorder which was previously an acquired aplastic anemia, which was previously thought to be a non-clonal disorder, we've been able to identify mutations such as B-core, B-core L1, and other abnormalities such as PIGA mutation to better understand the molecular abnormalities, which we even can find in bone marrow failure conditions. And I think that's very important, which has been done, work has been done greatly by the NIH and other international collaborators, including ourselves, and understanding acquired bone marrow failure syndromes and their molecular findings. So a couple of things we use. So when we're assessing a patient with aplastic anemia, back in the early 70s, one of the criteria that was established, and you'll find in all our textbooks, and we use also in a clinical framework, is the Comito criteria. And, because we know aplastic anemia is characterized by a hypocellular bone marrow, that's one of the criteria. But what we want to know is beyond the cellularity, does our patient meet 2 out of 3 of the criteria, such as based on your neutrophils, your reticulocyte count, and also your platelet count. A couple of things to keep in mind is that we have 3 different broad categories of aplastic anemia. We have moderate aplastic anemia, which these patients can stay stable for long periods of time because they don't meet the criteria for severe or very severe, or they may need a little bit of immunosuppressive therapy to be treated. And they can progress to severe aplastic anemia over time. So it's important to monitor these patients also. But severe aplastic anemia, by definition, which we'll be concentrating on today, is, basically you have a neutrophil count which of less than 500, and also reticulocyte count that's less than 1%, corrected, and less than 20,000 platelets. And in the major difference between severe and very severe is the neutrophil count, but it's important to keep in mind because treatments overlap for both of these conditions, but identification is important because of the risk of bleeding and infectious complications for our patients. So back to our patient. So our patient we walked through it, right? She had pancytopenia, no significant past medical history, but she had the infectious complication, and our bone marrow biopsy shows us she had a hypocellular bone marrow, for her age. So she's 39. So she should definitely have a higher cellularity, but it's 10 to 30%. And she had marked granulocytic hypoplasia, meaning her granulocytes, which are the neutrophils, were low in the bone marrow. And they noticed a nonspecific increase in T cells than B cells, and polytypic plasma cells, which were nonspecific. And as we can see here, her karyotype, which was normal, and so she had a normal female karyotype with no genetic abnormalities noted there. She also underwent additional testing. At this point, she did not have any on physical exam any phenotypic abnormalities that would put us in concern of inherited conditions. So that was ruled out early on for her. And also we got a thorough history from her up front to see if she had any siblings. Additional testing we did at this, so we got her PNH. So as we can see here, she had a low PNH clone. So here, keep in mind, so her PNH clone, she had a granulocyte clone of 35%. But her biggest clone, and when we talk about PNH, which I know Dr. DeCastro will be talking about this in the discussion, is we look at erythrocyte clones as type 1, which is no deficiencies and CD55 or 59, type 2, partial deficiencies in those markers on the red blood cells, and type 3, which is complete deficiency, which makes overt. In her case, her PNH was not active at diagnosis, but something to keep in mind as we follow her clinical course. So when we talk about the treatment paradigm, so taking our young female, so we know she's diagnosed with severe aplastic anemia. So now, she's 39, but note she did not have an HLA matched sibling donor. So what we did for her at that time, because this was back in 2013, we treated her with horse ATG plus cyclosporine. But something that's been added to our treatment paradigm is L-thrombopag, which we'll talk about as we move along. And you probably heard a lot about it from Dr. Bhavisha Patel. Horse ATG plus cyclosporine and plus or minus L-thrombopag, we give it to our patients. They're admitted to the hospital. And so this is where patients have severe aplastic anemia. And so for our patient, she was admitted to the hospital already. So she received horse ATG plus cyclosporine, because this was back in 2013 prior to the approval of L-thrombopag. And it takes about an average of 3 to 6 months to see a response. And in her case, she had a response. And we tapered the cyclosporin and followed the clinical course. But important to monitor the PNH clone in her case. But patients that don't have a response to immunosuppressive therapy, we have to think about, do they have candidates for that are greater than 40 or older, younger than 40. We think about upfront transplant for these patients. If they don't respond, is now there's different options for beyond matched sibling donors. And we think about treatment after matched sibling, unrelated donors, haploidentical transplant. And then other things we think about is, if they're not a transplant candidate, is we think about second courses of immunosuppressive therapies, such as with rabbit ATG. We'll talk about alemtuzumab in the relapse refractory setting, L-thrombopag also, which is approved in relapse refractory setting, anabolic steroids, and other supportive care. But in many of our young patients, we think about upfront transplant for these patients, and that's where it's important for HLA tissue typing to be completed upfront for our patients. So to talk about the backbone, so the backbone of aplastic anemia treatment starts, especially for severe and very severe, we talk about antithymocyte globulin. And what's important to keep in mind is horse versus rabbit ATG. Currently, so when they were compared head to head, we know horse did better than rabbit ATG in responses to our patients with severe aplastic anemia, and which makes up our backbone with ATG plus cyclosporin. This is a treatment that's administered in the hospital, where horse ATG is used up front for our patients and is 40 milligrams per kg once daily for 4 days in combination with cyclosporin. And this is made up our backbone for patients with aplastic anemia who need treatment to restore their blood cell production, which takes 3 to 6 months. Things to keep in mind with ATG is we watch for complications. That's why patients are admitted. So there's a risk of high blood pressure, there's a febrile, you can have fevers, there can be trouble with anaphylaxis, and there can be serum sickness also post-ATG treatment. So that's why it's admitted in a controlled setting, so we can make sure our patients are safe to receiving therapy. Other therapies that we can consider for our patients. So I mentioned alemtuzumab here, which binds to CD52, which is present on our B cells and T cell lymphocytes, and majority of monocytes and macrophages and NK cells. And what's important about this drug, I keep this here, it's commonly used in our patients in relapse refractory setting. We consider using this agent. But I've had patients where I was not able to use horse ATG or rabbit ATG, or I've had to consider alemtuzumab when there's concerns for renal failure. This is an important thing to keep in mind. Most of alemtuzumab, when we think of when we use it in clinical practice, it's used as a sub-Q injection, and we don't use the IV formulation commonly. And so most common formulation, we use sub-Q, where we give 3 milligrams on day 1, 10 milligrams on day 2, and 30 milligrams on days 3, 4, and 5, a total dose of 103 milligrams over 5 consecutive days in combination with cyclosporin. And we've had a lot of patients where we've been able to maintain them on this therapy. And over time, depending on their response, we use this therapy as maintenance therapy also. But this is something we can consider using in patients that may not be candidates for our antithymocyte globulin therapy. So as we previously discussed, L-thrombopag has definitely changed and improved our responses rates for patients with who were previously receiving ATG plus cyclosporin. So a couple of things to keep in mind. L-thrombopag is a thrombopoietin non-peptide agonist, which increases platelet production by building to and activating the human TPO receptor. It activates signal transduction pathway, so biological pathway to cause our differentiation of our stem cells. So it actually applies not only to platelets, but we've actually seen responses with our hemoglobin and with our white blood cell production with this agent, which is great, right? Because all of our cell lines are affected in different degrees. So first of all, L-thrombopag was approved in relapse refractory setting for aplastic anemia patients where treatment options are limited. And it was approved for response rates of around 40%. But when we looked at it in clinical trials from the NIH, when L-thrombopag was added to ATG plus cyclosporin, so remember, with ATG and cyclosporin alone, response rates are around 60 to 70%. But when we added L-thrombopag to this regimen, response rates were robust, above 70%. and which made the response early recovery of the hematopoiesis for our patients, where count recovery is important. And you can eventually wean patients off of agents, immunosuppressive therapies, including L-thrombopan. So this was an exciting drug approval for all of us in the field of bone marrow failure, and it's helped so many of our patients in their in a disease where treatment options are limited, but I think we're getting better at it. Additionally, there's clinical trials now with using other agents in relapse refractory setting, which are exciting, such as the study from our company Regeneron. And so I think there's a lot of things coming up in the pipeline working on our immune system, how best to serve our patients. And I think we're just at the edge of the iceberg. And I think we have a lot more to learn beyond the treatment paradigm, but also about the genetics of these bone marrow failure conditions. So back to our case. So our patient received horse ATG for 4 days, along with cyclosporin, with overall appropriate count recovery. She did not have an HLA matched sibling donor, but she remained dependent on immunosuppressive therapy to maintain her platelet count. So normally we tend to, wean immunosuppressive therapy after patients have a robust response after 6 months to a year. But some patients remain dependent on immunosuppressive therapy, which tells us about the immune-mediated biology of our aplastic anemia. But we tend to wean it to the lowest dose possible for our patients, but some patients are able to come off of it completely. So for our patient, she remained on low dose of cyclosporin, but remember, she also had a PNH clone we had to monitor very closely, even though she had no evidence of hemolysis and during her earlier course of therapy. But we're going to watch her course over the next 4 years to see what happened with her and see how we were able to monitor her, but also treat her condition. And keep in mind the close association with aplastic anemia and PNH. So over the course of 4 years, so this takes you at the time of diagnosis of aplastic anemia in 2013. As you can see, she had very low blood counts and she had low white blood cell count. So as we can see, her neutrophil count was around 500. Her platelets were low when this was a transfusion. Her hemoglobin was low. And so she received a standard ATG with cyclosporin. And as we can see, she had a beautiful, slow, steady, so she got supportive transfusions along with her cyclosporin. And as time went along, her counts continued to improve. So we're in December 2013. So think about it, she got treated in June. And by December 2013, she had overall resolved our cytopenias that are all improved, such as her white blood cells that improved, which can increase the risk of infections. Hemoglobin was normalized. But her platelets, as you see, did not all completely normalize, and except at one time point. But one thing we noticed is that over time in 2015, so from 2013 to up to mid 2015, we noticed that her white blood cell and her platelets weren't doing optimal. It's something that we monitored very closely. So as we went along in her course, she remained immunosuppressive therapy dependent. But in 2016, what we noted is here, we noted that she started having episodes of hemolysis. So keep in mind, she had that granulocyte clone around 35%. So at this point in 2017, we checked her PNH clone, and she had a type 2 PNH clone, which typically, if without evidence of recurrent hemolysis, we may consider watching these patients. So we had her in immunosuppressive therapy, and we treated her with steroids at this time, and she improved. However, she continued to have episodes, intermittent episodes every so often of hemolysis, which made it very concerning for us because it was her hemoglobin was dropping significantly, along with her platelet count. But her neutrophils maintained itself. So here we noted that 2 episodes of hemolysis, and then last was the 3rd episode, which made us think that, hey, here we need to start considering therapy. So she had 3 episodes of hemolysis in a very short period of time, where at this point we checked her PNH clone and we wanted to see, is her PNH clone evolved? So something to keep in mind is your clinician and your physician is going to be monitoring your PNH clone if it was present before, and to monitor for evolution of that PNH clone, because we want to make sure there's nothing else going on. But also beyond the concerns for hemolysis, we want to check for clonal evolution, because we know there's a risk, 10 to 15% risk of evolving of clonal evolution in patients with aplastic anemia to either MDS, and it can happen to MDS AML, or there's a risk of evolution to PNH. And at this time, we got her bone marrow biopsy to evaluate what is further going on. So Here's our other labs over the course of the 4 years. As we noticed during her episodes of hemolysis, she had elevated LDH, which is the intracellular marker that we monitor. She had one spike of elevated D dimer, but no history of clots. And we monitored that. But during her episodes of hemolysis, and towards the end, when we decided to start treating her for the PNH, we noticed her D dimer continued to elevate. So evidence of hemolysis was becoming more frank and evident on our clinical evaluation. Similarly, these are her labs in regards to her reticulocyte count. So here to keep in mind is she had a robust response for her aplastic anemia, but remember she had that PNH clone. So she had disease evolution of her aplastic anemia to PNH, which commonly closely are related to each other, and also reflects on the immune biology, immune-mediated complications of aplastic and PNH in conjunction with each other. So here we noted that, her hemolysis continued, and along her reticulocyte count was dropping, so she had pancytopenia. What we wanted to better understand is what is driving it, her disease. Is it the PNH or aplastic or a combination of both? So we monitored her PNH clone, just to go back, is that her 2013 clone, granulocyte clone, was about 35%. Her granulocyte clone in 2014 was 44%, but no evidence of hemolysis, so keep that in mind. Similarly, 2015, 2016, around 50% granulocyte clone, along we monitored her erythrocyte clone. But it was in 2017 we started noticing that there was a shift in her PNH clone. We noticed her erythrocyte clone and granulocyte clones were all changing. And what we wanted to find out what was going on, and what we learned is she developed PNH based upon her bone marrow biopsy and her flow cytometry. So we kept, PNH is it's an acquired somatic mutation in the PIGA gene, which causes defective synthesis in our GPR anchor proteins, which leads to the development of PNH and clinical manifestations. Note PNH PIGA mutation can be found in small number of hematopoietic stem cells in even normal individuals. But in patients with truly acquired paroxysmal nocturnal hemoglobinuria, which we would call in this case secondary PNH, because it evolved from a patient with aplastic anemia, it's important to keep in mind that there's PNH is characterized by hemolysis, so elevated LDH, low haptoglobin, and elevated retic. And it's due to the actions of the complement system. And because the complement system is not able to recognize the red blood cells, which are lacking the CD55 and 59. And this allows the complement system to readily lyse, meaning break apart the red blood cells in the presence of activated complement. And note, granulocytes and platelets are not as sensitive to the complement system as red blood cells are, which is the hallmark of PNH. And one thing to keep in mind when we're looking at PNH, we look at what type of deficiency do they have. Do they have a type 1, which is no deficiency, type 2, partial deficiency of these GPI anchor proteins, or do we look at type 3, which there's complete deficiency? And note, for our patient, she had a type 2 clonal long with no evidence of hemolysis, for which she was monitored. So close monitoring is very imperative in your clinical course. So pathophysiology of PNH. So it's an acquired disorder. This is not an inherited disorder. When we talk about it, acquired, meaning you were not born with this. So it's a stem cell disorder where you acquire a mutation in the PIGA genes, which makes your red blood cells more susceptible to the complement system. And there's a close interplay between your complement system and your coagulation pathway, which increases the risk of, which is the hallmark of the clinical manifestations of paroxysmal nocturnal hemoglobinuria. So here's a complex diagram, but I think this is an important diagram to keep in mind. The complement system is made up of a group of proteins that are part of our immune system. So our complement system is really important in recognizing and removing, recognizing any foreign object or foreign bacteria and getting rid of it, and viruses included. And so complement circulates in inactive form, but can be activated in the setting of trauma, infections, and stress. So keep in mind, in PNH, activated because of the lacking of the GPI anchor protein CD55 and 59, your complement system is not recognizing your red blood cells, making it much more susceptible to lysis, meaning the red blood cells will burst apart. And what's important to keep in mind, there's a close interplay between the complement system and the coagulation cascade, which leads to the clinical manifestations of PNH. So keep in mind, the FDA-approved therapies for PNH are eculizumab and ravulizumab, and most recently, pegcetacoplan for patients with PNH. So these are FDA-approved therapy, but there's so much more we're learning about patients with PNH, where in here we're learning about are there things we can target upstream in the complement system that may help us in managing our patients with PNH who may have extravascular hemolysis, which occurs in about 20% of patients. So these are some of the drugs in pipeline and research that we're learning more about. But I think we're going to be learning more about this as we go along in our established therapies that we do have for PNH and as we go along. So clinical presentations to our patients is varying degrees of anemia. So symptoms of back or abdominal pain can happen, headaches, fever, esophageal spasm, blood clots, renal insufficiencies, and pulmonary hypertension. Exacerbation of hemolysis can occur with infection, surgery, or transfusions. Note, aplastic anemia can be diagnosed both before or identification of PNH. So note, most of the time, I've had, our patient, like in this case and scenario, had aplastic anemia and PNH at diagnosis, right? And note that PNH patients, are present in greater than 20% of aplastic anemia patients and in patients with MDS. And there is an incidence of patients with PNH can evolve to leukemia too. And so that's something to keep in mind when treating these patients with bone marrow failure conditions. Thrombotic complications, which we can see with patients with PNH, which is one of the most feared complications of PNH, is venous thromboembolism, Budd-Chiari syndrome, it could be intra-abdominal cerebral or venous sinus thrombosis, or thrombotic tendencies during pregnancy. So having a very good multidisciplinary team is important in managing patients with PNH. Especially our goal is to early identification, treatment to mitigate the risk of thrombotic complications, which I know Dr. DeCastro will be touching upon with you guys. So labs that we discussed with our patient, she had elevated LDH, D-dimer, low hapto, and she had actually not an adequate reticulocyte count. So normally in patients with PNH, we see an elevated reticulocyte count, but in her case, it was decreased. So there's no specific morphological abnormalities to the red blood cells in PNH. So when you look at the smear, when we look at our patients with PNH, but there's not a specific thing that will tell me, hey, under the microscope, this is PNH when I'm looking at the blood smear. But the bone marrow may really reveal erythroid hyperplasia. In our patient, she had hypocellular bone marrow and she had erythroid hyperplasia. So it gave us an idea that she had both combination, which needed both treatment. So other things that can occur in patients with PNH is iron deficiency anemia because of chronic urinary loss from intravascular hemolysis. Commonly see, and you can see common degrees of leukopenia and thrombocytopenia, as you saw in our case. So diagnosis of PNH occurs with flow cytometry. So this is important that we monitor along the clinical course of our patients with PNH. And this is due to the increased sensitivity to detect small abnormal population because monocytes and granulocytes have shorter half-life, and that's where we look. And numbers are not affected by transfusion. So that's why we look at the granulocytes to get an idea of what is our estimated PNH clone. FLAIR assay binds selectively to high affinity GPR anchor proteins. So that's important as we know that our PNH patients lack CD55 and 59 on their cells. And it's a useful assay in assessing our granulocyte clone so we can better treat our patients, but also look at the erythrocyte clone of type 2 and type 3 in our patients with PNH. So treatments for patients with PNH include humanized monoclonal antibody eculizumab or ravulizumab, which binds to complement C5 in the complement system, inhibiting terminal complement activation, which decreases the hemolysis of RBCs and decreases the tendency of thrombosis, but does not fix the defect at the level of the hematopoiesis. So this is not a curative therapy, but it helps them in mitigating the complications of hemolysis for PNH patients. So it's important to get vaccinated 2 weeks prior to initiating therapy for our patients. But in urgent situations, we can consider using prophylactic antibiotics. And other therapies recently approved as pegcetacoplan that can be used in patients with PNH also. And just know that allogeneic bone marrow stem cell transplant is the only known cure for PNH, but is reserved for patients with severe pancytopenia and or hemolysis that's uncontrolled by C5 therapies. And now with other newer emerging therapies, this may not be, we will be considering using those in combination in clinical trials or as single agents in clinical trials, which, is exciting data to come and exciting findings to come to see how we can better serve our patients with PNH. Patients with PNH and bone marrow failure, like note one thing is like, in this patient, we treated our patients for aplastic anemia first. We did not treat this patient for PNH. So keep in mind the close association between these diseases and the importance of managing these conditions together in each individual patient, and each individual course is clinically different. So back to our patients. Due to recurrent episodes of hemolysis, patient was started on eculizumab. This was prior to the approval of revoluzumab and other therapies that are newly there. So note that within 3 weeks of starting therapy, she actually had nodular skin lesions, and there were actually thrombotic complications, and she had for which we had to do C5 therapy, and also restarted her C5 therapy along with steroids, cyclosporin, and anticoagulation so we could get her stabilized. And our patient was stabilized from that standpoint, and we were able to treat her aplastic anemia along with her PNH in this case to help improve her hematopoiesis. Our patient did eventually end up going to bone marrow transplant as a curative option because of her complex history of aplastic anemia and concerns of evolution to MDS due to later findings as her disease course did go along. But we did send her to bone marrow transplant due to early findings of MDS, and she's doing great. This is something to keep in mind when we're thinking about all of our patients and taking care of everybody, but also that we're learning more about new treatment options, the genomics. So I think the research and the clinical aspects of these diseases is becoming more and more exciting. We're learning more how better to take care of all of our patients. In conclusion, early recognition and management of aplastic anemia is imperative, acquired or inherited. Management entails a multidisciplinary team of hematology, blood bank, high-risk obstructives in the setting of pregnancy, genetic counselors, and support groups such as AAMDS and other support groups for individual diseases. Note, acquired aplastic anemia is closely associated with paroxysmal nocturnal hemoglobinuria. Close monitoring of the PNH clone is important as are signs and symptoms because you may have to consider treating our patient with PNH. Thank you very much for having me today, and I'll take any questions that you have today.
Thank you so much, Dr. Patel, for your excellent presentation. We have a number of questions, including some that were previously submitted. Let's get started.
Yes.
Our very first question comes from a patient who wants to know a little bit more about how you might manage aplastic anemia during pregnancy.
Great question. So, Julie and I were talking about this a little earlier. So, there's two aspects of aplastic anemia to keep in mind in pregnancy. So, from clinical experience, there's aplastic anemia that can occur prior to pregnancy, and that's something to keep in mind. So recently, I'm going to give you one clinical scenario. I had a patient who had thrombocytopenia prior to her pregnancy, but that was monitored very closely. But later on noted with pregnancy, it evolved into aplastic anemia. So it was a slow simmering aplastic anemia that was exacerbated by pregnancy. But there's aplastic anemia that develops during pregnancy also. And what I've had to do with these clinical cases scenarios, especially in pregnancy, is I monitor these patients very closely with high-risk obstructives. So in the setting where I'm severe, depending on what stage, if they're in first, second, or third trimester, close evaluation and monitoring is critical. So transfusional support is important. And also working closely with obstructives, in your blood bank, and making sure transfusional support's there, but making sure when we plan the pregnancy. A lot of times in aplastic anemia, I could say this, is that we try to not use immunosuppressive therapies because there's not that much data in pregnancy, but there is case reports used where we have, there's been reported cases of cyclosporin has been used in low doses in our patients with aplastic anemia, where their cytopenias are very profound. There's not data of using Promacta in these patients either. So we watch these patients very closely and manage them, and we do plan everything very strategically to ensure safe delivery of our newborns. So that's how we manage our patients with aplastic anemia during pregnancy.
Thank you so much, Dr. Patel, for that thorough answer. This patient wants to know that they've been a long time aplastic anemia patient, but were recently diagnosed with myelodysplastic syndrome, and they are wondering, do you need to treat the aplastic first, or do you treat the MDS first?
So in this case and scenario, most of the, as we looked at that picture of the continuum of the, bone marrow failure syndromes, We know MDS is a feared complication of aplastic anemia that can occur in 10 to 15% of patients. So in the setting of MDS, depending on the genetics, it's important to make sure that bone marrow transplant consultation is initiated and HLA tissue typing was performed, because the thing is, as a curative intent, we would want to make sure that our MDS is well controlled, but also depending on the stage of the MDS, you, as a curative intent, you would want to consider bone marrow transplant, allogeneic bone marrow transplant.
Great, thank you. We have a question from someone who I imagine is actually a healthcare professional. And they're asking, for community oncologists, where do we send for telomere measurement?
Great question. So, the two places, one of the places in the United States currently we use is Johns Hopkins. Dr. Mary Armani is at Johns Hopkins. We send our telomere testing to her to get that evaluated. In the setting in the community, when you're initially concerned about aplastic anemia, I think it's if there's high suspicion of aplastic anemia, I always recommend having the patient evaluated at an academic center, just because there's maybe potentials of clinical trials. But I think it's working together is really crucial. I have a lot of community doctors I work with. So, I think it's important to always reach out to because of due to the rarity of it, I think it's great to work as a team in taking care of these patients to ensure great care for them.
Thank you so much. This patient wants to know, is aplastic anemia overlapping with PNH? Does it only happen in adults, or is it something that can also happen in pediatric patients?
So it can happen in acquired. So I have young patients, like I'm going to just go with, because I'm an adult hematologist. So I have patients that are around the 18, 19 years of age. They, in acquired aplastic anemia, you can detect a small PNH clone, even in pediatric populations. I have had younger patients in their teens who have small PNH clone when there's immune-mediated acquired aplastic anemia.
Great, thank you for that response. Our next question comes, it probably is no surprise to you, but we do have several questions from patients who are inquiring about getting the COVID vaccine, or should they get vaccinated? Are there any health concerns related to getting vaccinated? And what are the factors that you consider in treating patients who are looking at vaccination?
That's a great question. So, one thing definitely, in full disclosure to all of you guys, there's limited data, right, in our patients with aplastic anemia and COVID vaccine at this time. But so in the setting, because I've seen a lot of complications with patients who are immunocompromised across the board. So for my patients with aplastic anemia, what I have done is that, I have been trying to vaccinate most of my patients who are immune competent, meaning that they have an adequate immune system in the setting that I know that they're going to be improved. They have normalized their counts, they have an adequate immune system, and they're doing well on immunosuppressive therapy. All of my patients have been vaccinated. In the setting where I think that we're still in the recovery phases, I've been cognizant about watching their counts and vaccinating them depending on their clinical course. But across the board, I have vaccinated all of my patients with aplastic anemia, but I've been watching them very closely along with their blood counts as their vaccinations have been occurring, just to see if they've had any complications with their vaccinations. Another question I've been asked recently, just to, in clinical context, a lot of patients have asked me, they're like, have you seen any clots in your patients with aplastic anemia and with PNH? I have not seen any blood clots in my patients with any of those types of complications at this time, because I know that's one of the reported complications of the vaccination, but I have not seen that issue in our patient population.
Thank you so much, Doctor. Our next question comes from a patient who wants to know, does LGLL play any part in aplastic anemia? And if so, what's the role?
Great question. So, one thing to keep in mind, so I've had patients, so we know that aplastic anemia, acquired aplastic anemia, is a T-cell mediated disorder. So you can find T-cell LGL in combination with aplastic anemia and PNH in small clones. So it's important to see if you have, when I'm evaluating patients with aplastic anemia, I do check for TLGL. I look at that, and as you saw in our patient, she did have a T-cell population, but it was not clonal. And so it's important to keep in mind, sometimes what we do is we monitor those patients very closely, because there's a lot of close associations with T cells in conjunction with acquired aplastic anemia and PNH. So it's something, usually I look at the severity of which disease is dominating the clinical picture. So I've had patients where they've had aplastic, PNH, and TLGL, but their TLGL was not playing a role. Their PNH was not playing a role because it was a small clone. Their aplastic was a role, but it was something that you have to monitor, but co-manage if clinically indicated.
Thank you so much. Our next question comes from, I think it's a community oncologist who's wondering can you treat aplastic anemia with single agent L-trombopeg?
So great question. Depending on the severity, there is emerging data. So for patients of moderate aplastic anemia, for instance, there's emerging data from clinical trials from the NIH that have shown that single agent L-trombopag can be used for patients with moderate aplastic anemia. In the setting of very severe and severe aplastic anemia, in newly diagnosed patients, I would not use a single agent L-trombopag for those patients. And depending on their age, their clinical presentation, and what is their in their phenotype, I would consider using ATG along with cyclosporine and L-trombopag in combination together, depending on their age and other underlying comorbidities. And that's and I would treat them in a setting where it's a hospital setting for those patients.
Okay, thank you so much. Our next question comes from a patient who was treated with ATG, horse, if it matters, in the late 80s. And they're doing well. They were in early clinical trials, I guess. I'm not really sure of the origin, but this patient wanted to know if they were recently told that it's failing and that they're experiencing side effects, and their HEMONC has suggested that the only way to cure this is to go to transplant. As someone who's in their mid-50s, who's otherwise healthy, is that what you would recommend, generally speaking, obviously knowing you don't provide medical guidance to people who aren't your patients?
Okay, in this case, I think what's important is, definitely, having a repeat bone marrow biopsy is crucial to confirm that you have relapsed aplastic anemia. I think that's really important to know at this point because you were treated in the 1980s. We want to see what the disease biology is. So I want to make sure that we rule out MDS or any AML type of component to your disease, and also check a PNH clone at this time. So depending on the severity of your disease and your clinical underlying comorbidities, that's something important to keep in mind. So many patients may not have options of going to bone marrow transplant because they lack a support system or they may not have an appropriate donor. In those cases, I may consider a repeat course of ATG because you had a really great response. But in the setting where transplant as a curative option, because we know ATG is not always going to, it's not going to be 100% cure. But in a setting where, depending on your underlying diagnosis, we may consider bone marrow transplant, allogeneic bone marrow transplant, because now there's more different options available for patients in this setting. But I think it's to have a very thorough discussion with your healthcare provider to make sure we make the right decision for you in that setting with all the available information.
Wonderful. Thank you, doctor. Our next question comes from someone who wants to know if aplastic anemia is due to Hep B, do you treat the Hep B?
You do treat the Hep B. That's a really good question. So a lot of times, just to make sure to emphasize that, when there is infectious etiology driving the aplastic anemia, you want to treat the infection because that can resolve the aplastic anemia. So we talk about that in CMV, viremia, EBV. We talk about it depending on the severity of the clinical context, you want to treat it. But in the setting, despite treatment, you still have aplastic anemia. You will still have to use the treatment paradigm that we use of the ATG, depending on the severity of it, a combination of ATG plus or minus cyclosporine plus or minus L-trombopag.
Okay, thank you. This patient wants to know, are aplastic anemias always neutropenic?
Not necessarily. So I think that's a great question. Depending on the severity of aplastic anemia, and I think that's where the criteria we use. So severe and very severe, we use the neutrophil count as one of our pivotal things to identify those patients. Not all patients have neutropenia. So I've had patients where they just have thrombocytopenia. I've had patients where they just have anemia with mild degrees of leukopenia without significant mild degrees of leukopenia with not any neutropenia. So in these patients, they're more classified towards moderate side. So when I think about those patients, depending on the clinical context of their clinical presentation or their symptoms or how things are going, we may consider low doses of immunosuppressive therapy for those patients, and to see if we could restore their production of their platelets, red blood cells, and even their neutrophils if that's the case and scenario.
Okay. This patient wanted me to note that it's gotten out of having to eat any family leftovers for years, and they'd really like someone to say that they have to be neutropenic forever. Sorry, I thought that was cute. Our next question comes from a patient who wants to know, what are the added risks for aplastic anemia patients who later develop erythrocytosis after transplant?
So that's a really good question. I think it depends on the clinical context of the erythrocytosis, because you want to make sure where's that erythrocytosis, what is it, a primary erythrocytosis or secondary? So evaluating the underlying etiology is very crucial in that case. So I think depending on the underlying cause of the erythrocytosis, that needs to be addressed if it's a primary or secondary cause.
Great, thank you. Our next question comes from a parent who has a child with aplastic anemia who wants to know, their child is not yet eligible for vaccine. The child has gone through ATG and will be returning to school in September. They have a lot of anxiety about this. Should they send their child back to school masked?
I would send them back to school. So I think this is definitely a multifaceted question. So let's take it this way. If the blood counts are normalizing and, in that sense, if they're within normal limits and they're no longer neutropenic, and so I think it's going to depend on the blood counts. But I do think if they're going to be in large crowded settings, if their counts have not recovered, I am going to recommend masking for them. Because the fact is, I do want to keep all of our patients safe and sound, because of right now we're definitely learning more about COVID-19, but with all the different variants, I would want to keep your child safe and sound in a large school setting. If they're crowded and their counts are not normal, they would need to wear a mask.
Thank you so much. And our final question comes from a family member whose loved one is going to transplant for a severe aplastic anemia, and is wanting to make sure that when their patient returns home, that they provide the most nutritious and healthy environment as possible. One of the concerns is that the patient is an avid gardener and a home gardener with orchids. They have gotten some initial advice from staff at their health center that they will need to get rid of all of the orchids in the home. Is this something that you're seeing as a recommendation, because this caregiver is concerned about the mental health of their patient?
I think this is a really good question, and I think it's very important. So I try to for all of our patients going to bone marrow transplant, definitely extra caution is taken because of their immune status at that point, because they're very immunosuppressed until their blood counts are improved. So I think in the setting, from the nutrition standpoint, it's important to eat cooked, having a well-balanced meal is imperative, meaning having cooked meals, having fruits and vegetables is crucial, making sure thoroughly washed and eating and drinking well, because nutrition is a big component of bone marrow transplant. Second component in regards to normalizing that living and coming home from the hospital. I try to, I always tell all of our patients, this disease doesn't define you. This is what's important, is making sure we normalize it in the setting that I tell them that it's like, you have to stay safe. Of course, I'm going to say, if you don't have an adequate immune system, avoiding large crowds, because we don't, that's going to be one thing. But in the home with plants and stuff, I am very cognizant of that with the patients. I tell them, like, what you can do is, even though you can't do your gardening yourself until we get you cleared from the transplant side and until you're immune competent, I tell them to put it outside of a window where they can continuously see their plants and all the things that they did do prior to going to transplant. So they maintain that normalcy for them in that setting till they're able to. So it's not saying that they're not going to be able to garden forever. They are going to be able to get back to gardening once they're better and safe.
Thank you, Dr. Patel, for sharing your time and expertise with us. If you'd like to watch this session again, it will be available on the conference platform in about an hour, where you just click on the session title and click replay, and then you can navigate to the on-demand tab on the platform. If we didn't get to your question today or something occurs to you later, please feel free to send an email to help, HELP, at aamds.org, or give us a call at 1-800-747-2820 extension 2. Be sure to visit our exhibit hall and visit our sponsors, and our next educational session will begin in about 15 minutes. On behalf of AAMDSIF, thank you for joining us today and for making us your resource of choice for bone marrow failure disease. The Medical Advisory Board and team are here to help you and your family as we have for the last 37 years. This concludes today's session. Thank you, Dr. Patel.
Thank you guys. Have a great day.